Hello, thank you very much for joining me on this webinar. You are in the webinar of Concussion, What's Vision Got to Do with It? Hi, I'm Dr. DeAnn Fitzgerald, and let's get started. I do have my email address on the title page, and you are very welcome to email me with any questions. I answer every one of them. If there's something that's really time sensitive, certainly you can get a hold of me at the office, but once again, I would use my email. So concussion, diagnosis of concussion, what we look for is it's the suspicion of injury and then evidence of injury. So if someone gets a tooth pulled, that wouldn't necessarily be that we're looking for a concussion. And then we look at that mechanism of injury. We don't essentially have to have a head injury. It can be a chest, it can be the body slamming against the ground. And then it would be nice if we had baseline information prior to that student athlete or that individual sustaining that injury, that we'd have some back data to take a look at. And then to look at symptoms. So concussion diagnosis is really symptoms and symptom provocation. And we want to look at their history. Did they have other concussions? And what was the recovery time on those other concussions? And do they have other medical history? Do they have a migraine history? Do they have ADD, ADHD? Do they have any type of mood or changes of that nature that would slow down perhaps that recovery? And then these student athletes will absolutely emerge out of their injury. So it can take minutes, hours, days for these symptoms to present. And I do have one of my case histories where it took a little bit longer to identify that. Now in my particular case, I make my office immediately available for any type of individual that has that, to guide them to where their care is at. So best practices and baselines that we could take, and vision's at the top of the list with vestibular, balance, cognition, and reaction time. This is absolutely a team effort. And whether you're the optometrist that wants to be in the front line and be that screening individual that can screen that student athlete and know then that they've sustained a concussion, to get them then to the appropriate care and be able to work in that PT, OT, athletic trainer, working with the MD to try and get that person better. So our assessment would include some of the three areas that you see here. Eye tracking, once again, is really getting a lot of play with probably right eye as a product that's able to do an office kind of assessment. We have the King Devic, we have the Nsuko, the DeAnn, and then VOMS. VOMS has been tested as very specific and very sensitive to concussion diagnosis and concussion management and treatment. And then we have to do, as an optometrist, we have to do our structure exam, and that's where every optometrist can get involved with this. If you don't want to do therapy, have no desire to do therapy, and that's fine. You just be that person that can also help with structure. So we look at VA, pupils, a partial cranial nerve exam. Once again, if they truly have a cranial nerve affect that's going on, that's probably not a concussion. That's going to be a mild to moderate traumatic brain injury. And then we have to be looking at maybe visual fields, checking the OCT of the optic nerve. There's been some papers written that indicate that there could be some swelling to the optic nerve after a concussion. And once again, I think we're all trying to experiment with that to see if there's any connection. And then we have to get into the functional exam, because as I mentioned before, a true concussion is going to be symptom and symptom provocation. So we're going to have to do some sort of dynamic type of exam to check to see how that's going. So dynamic visual acuity is one way to do that, and everyone within the medical community understands what that is. A balance, we can do a BESS. A sway is a particular balance test that can be done on your cell phone. And then there has to be some cognitive testing. So impact happens to be the cognitive test that's perhaps the widest known type of cognitive testing, but there's also vital signs out there. And then I like to do, obviously, reaction time, as I mentioned before. So Dynavision, SVI, synaptic, and then some of that functional testing can be done with NeuroTracker. So I look at it from the standpoint of the clinical trajectories. These were first introduced by Mickey Collins, who is one of the founders and creators of Impact. And one of the things that I find very successful, I use this with actually all my patients, but we have ocular, we have vestibular, we have cognitive fatigue, post-trauma migraine, cervical, and then anxiety trajectories. And as we go through this, what happens for concussion, as I mentioned, symptom and symptom provocation, is the first 24 to 48 hours, rest is key. Now that used to be different, where they said 7 days. We now know that we cannot put someone in a dark room and treat them like a mushroom, that we have to get them sleeping that 24 to 48 hours and get that brain to heal up. But then in the next 3 to 7 days, we have to get them moving in some fashion. We have to get them out of symptoms. And what happens is if we can identify which of the trajectories are perhaps causing the major type of symptoms, then we can better direct their care and better direct their treatment. And often the question that's asked to me is, how quickly will this progress? And one of the ways to find out is that if that trajectory is vision vestibular, or if that trajectory is anxiety, I have a completely different treatment idea that I might use in a different type of team member I might be able to work with that would help me get that student athlete back up and running. One of the things we have to take a look at is the sympathetic parasympathetic system, the autonomic nervous system. And what happens is that the parasympathetic is always on, and the sympathetic system, the sympathetic system is always on, and the parasympathetic system is kind of regulating how that sympathetic and parasympathetic get along. And the difficulty is that the parasympathetic goes offline, so to speak, and so the sympathetic runs without being tempered, and that's where we get that fight or flight. That's where we can get that pupil affect. So very important aspect to take a look at. And then what we found in my practice is that when we assess them for symptom and symptom provocation, a lot of times what happens is that we're looking at their neck and head, and then we're looking at how we can get out of that sympathetic affect. And oftentimes they get relief even from 3 different types of things, looking at the neck, looking at that symptom provocation, is that we can reduce their symptom affect in headache and dizziness. So it's a brain thing. So what ends up happening is 70% of our brain is dedicated to vision in some fashion. 80% of all sensory goes through our eyes. 90% plus individuals have a concussion will demonstrate 1 or more ocular affects. And if not addressed, these ocular affects can result in a delayed recovery. And 40% of these individuals will have ocular deficits or difficulties longer than 3 months. We've even found them up to over a year. So intervention is very helpful in the resolution of the ocular complaints and then also with the other trajectories. So most commonly reported symptoms, and this was a study done by Level in 2004, is that we see that headache goes across probably all the trajectories, but we go down and we can see dizziness. And dizziness can be an effect of vision, it can be an effect of ocular, it can be cervical. What we find is that if dizziness is present at the time of the injury, then they might have what's called a protracted recovery. It's going to be much more difficult maybe to get that student athlete up and running as quickly as we can if the dizziness is present at the time of the injury. And then if we have, we look at vision blurriness and double vision, very common, and light sensitivity. So ocular motor dysfunction following traumatic brain injury, and of course convergence insufficiency. This was a study done in 2012, and what that shows is that controls the population out there with convergence insufficiency without having an injury is 5%. Saccadic impairment was 0, pursuit impairment was 0. Really the accommodative dysfunction maybe is more common in that control population, but you can see that convergence insufficiency is a high specificity and sensitivity for concussion and concussion potential. And so are saccades and pursuits, and once again that accommodative dysfunction. So the common visual symptoms that we find obviously are the patient might come in with blurred or fluctuating vision. They'll complain about that. Once again, we're looking at the deficit of that accommodation. And there might be a slight prescription change. They will fluctuate with a little bit of an astigmatism. It's uncorrected, will give us that. So we really need to be doing that exam, and optometry really needs to be in the middle of that. Now, greater than half of the TBI patients or concussion patients will see double. They can't really tell you what that double is. Is it the word being double? Is it both eyes? And a lot of times the major cause of that double vision is convergence insufficiency. And that is a spatial orientation problem. And as a result, the 2 eyes are not working well together. And then, of course, eye tracking. What ends up happening is the VOR, the vestibular ocular reflex, is something that goes offline with that concussion. And that can inherently get involved with the ocular motor. So we have those eye tracking deficits. And then, as I mentioned before, we have the light sensitivity. It's a deeper brain affect. It's in that superior colliculus, and that gets offended. And when it gets offended, then we're really light sensitive with that. The non-visual symptoms that we need to be aware of is that they have reduced cognitive abilities. They feel like they have foggy brain, like they're a step or 2 behind themselves. And the balance difficulties with dizziness You know, the visual system is very strong. A lot of times it can hide those affects, but studies show that individuals with concussion or mild traumatic brain injury can have up to 30 days of a balance deficit. And then, of course, the headaches. The headaches are present in all the trajectories, but once again, we can find that toward the end of the day, if they're getting that headache or if it's with near point work, then once again, probably the visual system is guiding those symptoms. So the stats that are out there, that the King-Devic plus the BEST test, which is a balance test, plus the SCAT-5, which is used by the athletic trainers, those three tests put together can give a 100% diagnosis of a concussion. And then receded NPC, as I mentioned before, is 55 to 61% of those student athletes, and they're very sympathetic when you do that NPC. In fact, they might even push it away from you because they can't tolerate it coming at them. And then, as we mentioned before, the decrease in accommodation. 91% of mild traumatic brain injury will have a prefrontal cortex affect. What I'm saying is that the frontal lobe is affected, so that means those executive functions, and then that perseveration of thought. Those are the types of things that show up in 91% of athletes or individuals that sustain a concussion will have that. 89% of mild traumatic brain injury or concussion will have a musculoskeletal problem, which is that neck and back. So that's why it's so important that we understand the trajectories, because we can have a neck problem that can appear to be an eye or a vestibular problem. And so we need to be able to rule those out. And I think, once again, it has been of late that concussion plus no solution is hysteria. And I believe that, once again, we have a solution for that. And that solution is sports vision performance. There's a paper written by Joe Clark who shows that in 5 years of doing sports vision performance, 2 weeks prior to the season, he was able to reduce concussions from 21 concussions down to 1, and that concussion lasting about 7 days. And that's a study that was done. You need to take a look at that. So the core essence of our sports vision performance is using something like a hand motion affect eye-hand motor, with synaptic dynavision being at the top of the list, and then probably our closer being neurotracker, which uses a cognitive affect to help us. So thoughts. So cognitive issues that linger are showing up as unresolved vision vestibular affects. And anxiety trajectories is showing as a consequence of unresolved vision vestibular. And cervical issues are more prevalent than previously reported. So what we have to do is we have to really rule out those top trajectories right there to see where the symptoms are coming from. So the dorsal stream back in 2011 was suggested that reaching the posterior parietal cortex, and the parietal lobe takes in all sensory information. And we've come up with 3 distinct pathways that come out: the parietal prefrontal pathway, the parietal premotor pathway, and the parietal medial temporal pathway. And this really gives credence to the neuroanatomy and neurophysiology behind the therapies that go with concussion and concussion management. So the peripheral pathway, of course, that's the initiation of eye movements. It gives spatial memory. That pathway helps with that top-down executive function, just like we talked about. 91% have some sort of prefrontal affect, and this is the motor pathway that we look at. And then the parieto-premotor pathway has the 2 projections. One's dorsal, one's ventral, but this is where we get into that eye-hand motor where you're reaching. And so by having deficits in this pathway, it'll show that reaching and touching using a dynavision or a synaptic, or even using some sort of sticky notes on a wall and reaching to them and having that accuracy is this parieto-premotor pathway. I think more commonly, and I wanted to show this, that we talk a lot of times about the 3 visual pathways that I just mentioned. And sometimes these, the way that I'm going to explain these in the next 3 slides, are a little bit more palatable. But once again, I find that the neurophysiology, neuroanatomy pre-slides give us more credence as to why these work. So we do have the cellular part of it. So we have the parvocellular, which is your occipital lobe, which would be your what pathway and ventral. And then you have the magno, which is 18%. That's midbrain wear. And then we have the conial cellular, which is about 2%. In the central focal parvo what ends up happening is that's attention, concentration. That's a slower type of mechanism for that. That's where it gives us our acuity. And it's mostly cortical, so it's a higher processing. We have the peripheral ambient, which is spatial. That's posture and balance. It's movement. And that change in it is pre-conscious. We're not, and subconscious. It's not something we're fully aware of. When an athlete says that they're in the game and they're in the flow of that is kind of this peripheral ambient Magno wear. And so 20%, roughly 18 to 20% of all nerve fibers of the eye do not go to the occipital cortex. They go to the midbrain, and they help us with motor. And that's where, once again, that spatial affect, that pre-conscious, proactive, receives that feedback from that cortex. And what happens is that it brings forward all the possibilities. If I'm going to reach for a glass of water and I change my mind and I'm reaching for a pen, it allows all those possibilities to go online. And when we have an